A 24-year-old female, 29 weeks pregnant, presents with dyspnea and fatigue at rest. She also reports chest pain and syncope a few days ago. Many of these symptoms are present during normal pregnancy. The worsening dyspnea, which is now occurring at rest, the chest pain, and syncope are worrisome signs and should alert the clinician into doing further workup. On physical exam, she has many signs consistent with normal pregnancy, but there are other signs that are worrisome. For example, the left parasternal heave and the loud P2, which should make you think of increased right ventricular pressure. EKG shows sinus tachycardia. The objectives of this lecture is to provide an overview of pulmonary hypertension and pregnancy, to describe the pathophysiology of pulmonary hypertension and how pregnancy may worsen this condition, and the treatments available for pulmonary hypertension, especially in the setting of right ventricular dysfunction and failure. Pulmonary hypertension is a rare disease with different causes. Despite improvements in treatment options, it still carries a grave prognosis. Pulmonary hypertension is described as an increase in mean pulmonary artery pressure greater than 25 millimeters of mercury at rest, as assessed by right heart catheterization. The mortality rate of pregnancy and pulmonary hypertension is very high, between 25 and 60%. The latter indicates previous literature, whereas the former indicates more recent data with the use of targeted treatments, the timely institution of these treatments, and early planned delivery. Despite improved prognosis, pregnancy is prohibited in women with pulmonary hypertension, and when pregnancy occurs, termination should be considered. When pregnancy continues, it is best if it is managed by a multidisciplinary team in a specialty center. As just stated, the diagnosis of pulmonary hypertension is defined as mean pulmonary artery pressure greater than 25 millimeters of mercury, using right heart catheterization. Realistically, echocardiography, through its widespread use and improved techniques, is considered a great screening tool for pulmonary hypertension, keeping in mind that with echo, you are measuring right ventricular systolic pressure and not mean pulmonary artery pressure. There are many factors that need to be taken into consideration when using echocardiography, specifically the presence of advanced lung disease, PVCs, and inaccurate estimates of right atrial pressure derived from the IVC dimensions, and then applying it to the modified Bernoulli equation. Here is the parasternal long axis of the heart. This is the RV, this is the LV, and here is the left atrium. As you know, blood flows from the left atrium down to the left ventricle, and then through the outflow tract, which becomes the aorta. Right ventricle is always compared to the left ventricle, and it should never be equal to or greater in size. Because of the variability obtained using echocardiography, and given the gravity of the diagnosis of pulmonary hypertension during pregnancy and its ramifications, the diagnosis of pulmonary hypertension must be confirmed by right heart catheterization before recommendations are made. The World Health Organization divides pulmonary hypertension into 5 groups. These groups are organized based on the etiology of the condition. It is important to note that Group 1 is called pulmonary arterial hypertension, but all 5 groups fall under the category of pulmonary hypertension. Group 1 are diseases that affect the pulmonary artery directly. Group 2 has to do with the inability of the left ventricle to pump effectively, which in turn causes blood to back up and therefore affects the pulmonary pressures. Group 3 is any lung disease that causes hypoxemia, which is a potent pulmonary vasoconstrictor. Group 4 is the chronic thromboembolic pulmonary hypertension group. And Group 5 is the grab bag group, for miscellaneous entities that are not entirely understood yet. Group 1, called pulmonary arterial hypertension, most often originates from a predisposing state, with one or more inciting factors that could be classified as idiopathic, genetic, environmental, are associated with other medical conditions. The incidence of idiopathic pulmonary hypertension is estimated to be 5 to 6 per 1 million in North America and Europe, with a marked female predominance, male to female ratio of 1 to 1.7, and the mean age at the time of recognition is approximately 37 years. BMPR2 remains the major genetic contributant to disease pathogenesis. Environmental factors include multiple drugs and toxins, such as anorexogens. Other drugs considered to be likely or possible causative agents for pulmonary arterial hypertension include amphetamines, tryptophan, cocaine, and certain chemotherapeutic agents. Pulmonary arterial hypertension is a recognized complication of a number of inflammatory conditions, including schistosomiasis, that although uncommon in the United States, is the most common form of PAH worldwide, followed by congenital heart disease. Connective tissue, rheumatologic, and infectious diseases such as HIV are also associated with the development of PAH. These four insults cause pulmonary vascular damage, which includes inflammation, endothelial cell dysfunction, thrombosis, and smooth muscle cell dysfunction. Inflammation is a complex series of interactions that occurs among cells and factors that can arise in response to an insult, such as trauma, infection, ischemia, toxins, or autoimmune injury. There is evidence that both the innate and adaptive immune system is activated, mainly comprised of TMB lymphocytes, macrophages, dendritic, and mast cells. The cytokines and chemokines subsequently produced may propagate further inflammation, play a role in leukocyte recruitment and trafficking, drive vascular remodeling, and cause contractility and proliferation of vascular cells. In addition, autoantibodies are increased and directed against the endothelial cell, causing apoptosis. Normal pulmonary endothelium is characterized by a significant heterogeneity, and its main functions include vascular tone, homeostasis, leukocyte trafficking, transduction of luminal signals, production of growth factor, and barrier function. The endothelium plays a role in the maintenance of normal coagulation through various substances. For example, prostacyclin and nitric oxide are synthesized by the endothelium and have antithrombotic and antiproliferative properties. If there is a relative deficiency of these molecules, as occurs with endothelial dysfunction, thrombogenicity and smooth muscle hypertrophy occurs. Endothelin, which is also produced by the endothelium, is overexpressed during endothelial dysfunction, promoting vasoconstriction and proliferation of smooth muscle cells. In addition, von Willebrand factor, which is synthesized by the endothelium, is dysfunctional in pulmonary hypertension, and further highlights a state of altered hemostasis, platelet dysfunction, and thrombosis. The summation of all these activity leads to luminal narrowing and slowing of blood flow, further propagating thrombosis formation. Prostacyclin, endothelin, and nitric oxide not only affect vascular tone, but also promote vascular remodeling and therefore represent logical pharmacological targets. The pathophysiology of Group 2 pulmonary hypertension is very different from Group 1. The main culprit here is left ventricular failure, which causes backup of blood to the lungs, leading to pulmonary effusion and edema. Although this is not a true narrowing of the pulmonary blood vessels as seen in Group 1, the raised pressure that occurs within the pulmonary system can eventually lead to an adaptive narrowing, which can further increase the workload of the right ventricle. Group 3 consists of hypoxic lung diseases that cause vasoconstriction of the pulmonary arteries, a defense mechanism usually designed to protect the lungs from too much blood flow to areas that are damaged. Eventually, This vasoconstriction becomes widespread and causes pulmonary arterial hypertension, which increases the workload of the right ventricle. Group 4 is called the chronic thromboembolic pulmonary hypertension group, a disease entity caused by blockage of the pulmonary blood vessels from unresolved blood clots, leading to an increase in pressure within the pulmonary circulation, which eventually leads to remodeling of this vasculature. Group 5 is the miscellaneous heterogeneous group, where the physiology and pathophysiology is now well defined and unclear at this time. Some of the diseases to note in this category are chronic hemolytic anemias, splenectomy, sarcoidosis, vasculitis, thyroid disorders, and chronic renal failure. Here's another picture of a blood vessel undergoing the process of smooth muscle hypertrophy and remodeling that will eventually lead to stiffness and fibrosis. Early in pregnancy, the plasma volume starts to increase so much that by the end of the second trimester, there is a 40% increase. Red blood cell mass increases between 20 and 30%. The increase in stroke volume causes a concomitant increase in cardiac output. In order to accommodate these changes, systemic vascular resistance decreases. Later in pregnancy, heart rate begins to increase to maintain cardiac output. During labor, delivery, and postpartum, the cardiac output and blood volume continue to increase mainly because of pain, anxiety, volume shifts, and the autotransfusion of blood during uterine contractions. In healthy pregnancy, the pulmonary vasculature adapts to this increase in preload by vasodilating, preventing the pulmonary pressures from rising. Women with pulmonary hypertension are unable to cope with these hemodynamic changes as a result of the pulmonary vascular remodeling that has occurred. They are unable to accommodate the excess preload, and thus pulmonary pressures become even higher and the right ventricle begins to fail. In women with Eisenmanger's syndrome, the combination of fixed pulmonary hypertension and decreased systemic vascular resistance leads to increased right-to-left shunt with systemic hypoxemia. Over time, the right ventricle hypertrophies, enlarges, and eventually decompensates. Eventually, this narrowing of the blood vessels makes it harder for the right heart to pump blood through the lungs, similar to how much harder it is for water to flow through a narrow pipe compared to a wider pipe. These changes eventually result in increased workload of the right ventricle, an adaptive response to the pressure overload, mainly in the form of muscular hypertrophy. If left untreated, the right ventricle will then dilate to further compensate for increased preload and to maintain stroke volume according to Frank-Starling mechanism. Right ventricular cavitary dilation may impair left ventricular diastolic filling, contributing to global pump dysfunction. Planned early deliveries at 32 to 34 weeks before clinical deterioration is an important contributor to good outcomes in several studies. Women with mild pulmonary hypertension may have their deliveries extended to 34 through 37 weeks. In terms of which method of delivery is better, C-section or vaginal, we just don't know, and there are very limited reports. On one hand, vaginal delivery is associated with autotransfusion of blood with every uterine contraction, but there is less blood loss, surgical stress, and hemodynamic instability. And C-section is associated with more venous thromboembolic complications and more fluid shifts. It appears that the general consensus seems to reserve C-section for patients that have obstetric indications for an operative delivery. It is important to note that most maternal deaths occur postpartum and are likely influenced more by fluid status and hemodynamics rather than the mode of delivery. Studies indicate that general anesthesia is associated with worse outcomes compared to epidural or spinal anesthesia, possibly because general anesthesia is known to cause increase in pulmonary pressures and cardiodepression. Here are two landmark studies depicting the mortality for these three groups. It is known that pregnant women with congenital heart disease and Eisenmanger's phenomena have a 28% mortality. Pregnant women with idiopathic pulmonary hypertension have a 17% mortality, and any other causes of pulmonary arterial hypertension has a 33% mortality. According to a systemic review, all published records of pregnancies in women with pulmonary arterial hypertension between 1997 and 2007, specific PAH treatment leads to improved outcome. Mortality in patients with idiopathic pulmonary arterial hypertension decreased from 30 to 17%. Let's discuss the management and treatment options of pulmonary hypertension during pregnancy. It is important to note that the treatment modalities we will be discussing mainly pertain to groups 1 and 4. Groups 2 and 3 treatment modalities mainly consist of correcting the underlying left ventricular dysfunction and underlying lung disease, respectively. It is important to note that using vasodilatory drugs in non-pregnant patients with pulmonary hypertension from chronic lung disease has been studied with discouraging results and are not likely to benefit pregnant patients with this condition. Group 5 is the grab bag group for miscellaneous entities that are not entirely understood yet. Right ventricular dysfunction is a principal predictor of adverse outcome in patients with pulmonary hypertension. Mortality from right heart failure is between 30 and 48%. Causes include alterations in preload through its effect on myocardial fiber length and diastolic filling, decrease in contractility, and increase in afterload. Although pulmonary artery catheters do not affect outcome in acute lung injury, they provide crucial hemodynamic information in acute right ventricular failure, particularly when used in combination with echo and indices of tissue oxygenation. They also allow the evaluation of the response to pharmacologic therapies and drug titrations. This is a treatment overview algorithm for right ventricular failure secondary to pulmonary hypertension. Important to note is the modification of any triggers, the optimization of fluid balance, the decrease in right ventricular afterload, the optimization of cardiac output and perfusion pressure, and to address the question, is transplant even an option? Right ventricular failure is the most common cause of death in pregnant patients with pulmonary hypertension. Increases in pulmonary vascular resistance leads to difficulty for the right ventricle in handling the increased venous return that occurs in pregnancy. The cornerstone of management is to lower the pulmonary vascular resistance and maintain ideal intravascular volume, best tolerated by the challenged RV. Mechanical ventilation, especially with high tidal volume and PEEP, can cause adverse hemodynamic effects secondary to its increase on pulmonary vascular afterload. Care must be taken to avoid excessive hypercapnia and its increase in pulmonary artery pressure. Adequate oxygenation is of utmost importance to avoid increase in right-sided afterload due to hypoxic pulmonary vasoconstriction. Aim for oxygen saturation greater than 92%. Right ventricular function is highly volume dependent, and a careful balance with optimized preload and decreased afterload is essential. Because the pregnant pulmonary hypertension patient has right ventricular failure as a result of dilation and overwhelming the Frank-Starling mechanism, diuretics are paramount in the treatment strategy. Remember, too much preload will cause the intraventricular septum to shift leftward, decreasing left ventricular cardiac output. Too little preload deprives the right ventricle and leads to a decrease in cardiac output. One of the most important interventions to reverse right ventricular failure is to reduce right ventricular afterload through the use of pulmonary vasodilators or pulmonary artery hypertension targeted therapies. The importance of reducing RV afterload is emphasized by the rapidity by which RV function is restored after pulmonary endarterectomy and lung transplantation. Calcium channel blockers are mainly reserved for women with group 1 pulmonary arterial hypertension who show a positive response to vasoactive testing. For non-responders, they are contraindicated and are not advised in Eisenmenger syndrome. Vasoreactivity is determined during right heart catheterization. The most widely used calcium channel blocker in PAH is nifedipine and diltiazem. During pregnancy, nifedipine seems not to be associated with fetal toxicity, but it is tocolytic and may cause placental hypoperfusion from hypotension. Diltiazem is fetal toxic in animal studies, although retrospective review did not reveal important risks for the fetus. Both drugs should only be used in pregnant women when the benefit clearly outweighs the risk. In therapy-naive patients with pulmonary hypertension and right ventricular failure, intravenous prostacyclin derivatives are the initial treatment of choice, although care must be taken to avoid systemic hypotension. It needs to be emphasized that intravenous epoprostenol remains the only pulmonary arterial hypertension therapy for which survival has been demonstrated in randomized control trials. Once the patient has been stabilized, oral therapies with endothelin receptor antagonist and PDE5 inhibitors may be added with or without later withdrawal of the prostanoid. Prostacyclins activate cyclic AMP, resulting in pulmonary and systemic vasodilation and inhibition of platelet aggregation. They can be given inhaled or intravenously. Epoprostenol and treprostinil are available parenterally. Iloprost is given by the inhaled route with concentrations in the pulmonary circulation and has the theoretical advantage of avoiding some of the systemic side effects. Epoprostenol is the preferred prostacyclin in the ICU because of its short half-life and potent effects, but its use is limited by dose-dependent side effects, for example hypotension, headaches, and GI symptoms. Abrupt discontinuation may lead to rebound pulmonary hypertension and possibly death. Endothelin receptor antagonists block the endothelin receptors in vascular smooth muscles and endothelial cells, attenuating endothelin's vasoconstrictive, proliferative, and pro-inflammatory effects. Its use in the ICU is limited because of its long half-life, approximately 5 hours for bosentan, and potential hepatotoxicity. Bosentan has been shown to have deleterious effects on the fetus in animal studies, although there are case reports with its use with successful fetal outcomes. Inhaled vasodilators, such as nitric oxide, might be used as supplemental therapy, especially if the prostanoids are causing systemic hypotension. Inhaled nitric oxide mediates pulmonary vasodilation by increasing cyclic GMP. It is rapidly inactivated by hemoglobin in the pulmonary capillaries, thus preventing systemic hypotension. Its effects are limited to ventilated lung areas, attenuating hypoxic pulmonary vasoconstriction, decreasing pulmonary artery pressure and pulmonary vascular resistance, and improving oxygenation without increasing intrapulmonary shunt fraction, which may aggravate hypoxemia in patients with lung disease. Inhaled nitric oxide may be of particular benefit when combined with inodilators like dobutamine and milrinone. The phosphodiesterase inhibitors work similarly to inhaled nitric oxide by blocking the degradation of cyclic GMP, which causes pulmonary vasodilation. Sildenafil and inhaled nitric oxide may work synergistically. Some interesting things about sildenafil is its unique inotropic effects on the hypertrophied right ventricle and its ability to decrease right ventricular mass in pulmonary arterial hypertension patients. Be careful with dramatically decreasing the right-sided afterload and what effects it might have on the left side of the heart, especially if left ventricular diastolic dysfunction is present. In this scenario, the immediate dramatic reduction in pulmonary vascular resistance can lead to a rapid increase in right ventricular cardiac output that may overwhelm the maladapted left ventricle, resulting in pulmonary edema and worsening right ventricular failure. The beta-1 agonist dobutamine augments myocardial contractility and reduces right and left ventricular afterload, which makes it the preferred catecholamine for patients with right ventricular failure. However, its use might cause tachycardia and its adverse effect on diastolic filling. Consequently, agents that don't have chronotropic properties, such as milrinone, may be preferable in some patients. Systemic vasodilation may limit the use of these agents or require the additional use of a systemic vasoconstrictor, such as norepinephrine. Care must be taken to ensure pulmonary vasoconstriction does not occur with escalating doses. Vasopressin may be an alternative to norepinephrine because of its systemic vasoconstriction but pulmonary vasodilation properties. Epinephrine also increases inotropy at low doses but can increase afterload at higher doses. Provided you have done all of the above, the final treatment modality depends on whether the patient is a heart-lung transplant candidate or not, and is it possible to realize transplantation in a reasonable time? If the answer is yes to any of these questions, then consider doing the following surgical interventional treatments. These are available for short-term treatments of pulmonary hypertension, mainly for groups 1 and 4. There is very little role, if any, for these procedures in groups 2, 3, and 5, as the treatment modality is aimed at treating and controlling the underlying issue. In addition, these treatment modalities are usually implemented for patients with potentially reversible right ventricular failure, unresponsive to or intolerant of medical therapy, or for those with disease progression despite maximal medical therapy. Surgical or percutaneous correction is also used in right ventricular failure due to valvular or congenital heart disease. All interventions should be performed before end organ dysfunction occurs. Furthermore, surgical or mechanical support is unlikely to benefit those with advanced right ventricular dysfunction and/or massively elevated pulmonary vascular resistance. The vast majority of PAH patients with an indication for transplantation receive bilateral lungs, as reported by the International Society for Heart and Lung Transplantation Registry. The overall 5-year survival following transplantation for PAH is estimated at 45 to 50%. Patients in Group 4, CTAF, presenting with right ventricular failure are generally treated according to the same principles just discussed. One important consideration is the likelihood of a new episode of acute pulmonary embolism. Old thrombotic material is fully organized and therefore not amenable to medical therapy. But fibrinolytic therapy may be considered if there is a high likelihood of an acute on chronic event. If patients with CTEPH cannot be stabilized with medical management, emergency pulmonary endarterectomy should be considered. Of note, this procedure is different from pulmonary embolectomy. The symptomatology of pulmonary hypertension is largely based on the mean RA pressure. Balloon atrial septostomy is a deliberate iatrogenic puncture of the atrial septum or a patent foramen ovale, causing blood to divert from the right to left atrium, causing the right atrium to decompress and reduce the mean right atrial pressure. This procedure increases preload and cardiac output in cases of failure of maximal medical therapy, persisting right ventricular failure, and/or recurrent syncope, as a bridge to transplantation and when no other therapeutic options exist. This right-to-left shunt can increase cardiac output slightly enough to relieve fatigue symptoms, although at the cost of desaturation. The procedural risk of a cath study on a sick patient with hypertensive lungs is high, and even a small fall in systemic oxygen saturation can be counterproductive. Stepwise balloon dilation is the procedure of choice. Refractory hypoxemia can develop from balloon overdilation during atrial septostomy and is the most common cause of death in this procedure. Balloon atrial septostomy is contraindicated in severe right ventricular failure and should not be offered in patients with right atrial pressures greater than 20 millimeters of mercury, significant hypoxemia, and/or high pulmonary vascular resistance index. VA ECMO should be considered in patients with refractory hypotension and/or signs of progressive secondary organ dysfunction, especially when transplantation is a realistic option. Maintaining cardiac output and preventing secondary organ failure are the most important objectives. The use of VA ECMO has become the preferred bridging strategy for patients with right ventricular failure in some high-volume transplantation centers. With ECMO, the right ventricle is immediately unloaded. Pulmonary arterial hypertensive therapy and catecholamines are usually no longer required, and the perfusion to all other organs dramatically improves. In women with Eisenmanger's physiology, VV ECMO will allow oxygenated blood to shunt from right to left if the systemic vascular resistance is lower than the pulmonary pressures. This novel approach can be used during delivery and recovery, allowing maternal hemodynamics to stabilize and optimizing fetal oxygenation. If at any point decompensation occurs, cannulation for VA ECMO, if appropriate, can be pursued. The use of the mother's pre-existing right-to-left shunt creates a physiological VA ECMO circuit that can be used in the event there is a hemodynamic collapse and allows the ability to maximize fetal oxygenation. If systemic hypertension were to occur while on VV ECMO, hypoxemia may ensue from left to right shunt reversal, and hemodynamic collapse can occur. Once the patient is off VV ECMO and is on appropriate pulmonary vasodilating medications, it is important to keep the systemic afterload high to minimize right to left shunt. Anticoagulation therapy is usually prescribed in women with idiopathic inheritable PAH and PAH associated with anorexigens. It is also considered in groups 1 and 4, depending on the underlying disease. In women with portal hypertension or Eisenmenger syndrome, the risk of bleeding is often elevated from either esophageal varices or hemoptysis, and the use of anticoagulation is therefore controversial. Warfarin should be avoided during early development of the fetus, as it is associated with embryonic toxicity, usually between the 6th and 12th week of pregnancy. Later in pregnancy, there is a small risk of CNS abnormalities, and the risk of fetal hemorrhage is present throughout pregnancy. Unfractionated heparin and low molecular weight heparin are larger molecules that do not cross the placenta. As the time of delivery approaches, the use of unfractionated heparin is preferred because it is more readily reversible in the event of hemorrhage. In conclusion, pregnant women with pulmonary hypertension have a high morbidity and mortality, despite significant improvements in prognosis in the past 2 decades. They should be advised against pregnancy. Pregnant women with pulmonary hypertension that choose to continue their pregnancy should be managed by a multidisciplinary team in an expert center. Early institution of targeted PAH therapy and early planned delivery may contribute to improved outcomes. Thank you very much, and have a good day.